At the outset, I would like to thank the State Academic Cell of KGMOA for choosing this topic, one which is most relevant in our day-to-day practice. Suppose we are sitting in a busy OP and almost finishing our work. The last patient, we would like. എല്ലാവരും ഒന്ന് മ്യൂട്ട് ചെയ്താൽ നന്നായിരുന്നു. ഇപ്പൊ ഡിസ്റ്റർബൻസ് ഉണ്ടെന്ന് തോന്നുന്നു. Suppose we are sitting in a busy OP, almost finishing our work. The last patient we would like to, we want would be definitely a case of vertigo. This for the simple reason that the symptom of vertigo or a patient presenting with vertigo can have a multitude of problems. The underlying cause may be very complex one. It may vary from a benign condition to a more serious one. It may vary from a peripheral one to a central one. The symptom may be a reflection of a localized disease to a more systemic one. So this makes today's topic even more significant. And we are really lucky to have a specialist in the field, one among us, to talk in detail about this problem. Vertigo, when to review or refer. That's the title of this topic. And the person who is handling this topic is Dr. ANJU, who is an ENT surgeon in General Hospital, Ernakulam. ANJU did her MBBS from Government Medical College, Kottayam, and did her post-graduation M.S. in ENT from Goa Medical College. Her field of interest is vertigo, and she has done her fellowship in neurotology and vestibular disorders from Anaya Healthcare, Bangalore, and also had her certificate course in vestibular disorders, assessment and management of vestibular disorders from Ernakulam Medical College. A vibrant and enthusiastic clinician and an excellent academician, Dr. ANJU has done several presentations in various scientific platforms, including ours. And most of us will be remembering her excellent presentation on mucormycosis during the COVID times. It's my privilege and pride to welcome vibrant ANJU, who is also a hardcore KGMOA person and an excellent leader, who was the vice president of Kannur branch of KGMOA. I once again thank the academic cell for selecting this topic, and with great pleasure invite Dr. ANJU to handle the topic. Over to you, ANJU. Thank you.
Thank you, sir. Can I share my PowerPoint?
Sure. ഒരു റിക്വസ്റ്റും കൂടെ, എല്ലാവരും സെഷൻ കഴിയുന്നത് വരെ ഓഡിയോ മ്യൂട്ട് ചെയ്യുക. സംശയങ്ങളുള്ളത് യു ക്യാൻ പോസ്റ്റ് ഇൻ ദ ചാറ്റ് ബോക്സ്, ആൻഡ് ഇഫ് ടൈം പെർമിറ്റ്സ് വിൽ ക്ലാരിഫൈ ദി ഡൗട്ട് അറ്റ് ദ എൻഡ് ഓഫ് ദി സെഷൻ. താങ്ക് യു ഓൾ.
സർ, ഒരു ഡൗട്ട്, ഈ സൂം മിനിമൈസ് ചെയ്യാനുള്ളത് എവിടെയായിരുന്നു?
Vipin?
ഡോക്ടറുടെ സ്ലൈഡ് ഷെയർ ചെയ്യാവോ? ഹലോ, എന്താ പ്രശ്നം? ഇപ്പൊ ക്ലിയർ അല്ലേ? ശരിയല്ലേ?
വരുന്നുണ്ടോ?
വരുന്നുണ്ട്. ഇനി സ്ക്രീൻ ഷെയർ കൊടുക്കും. ഇപ്പൊ ഹോം അല്ലേ? മുകളില് ആനിമേഷൻ ട്രാൻസിഷൻസ്. യെസ് ഡോക്ടർ. ഓക്കെ.
ഈ ഹെഡിങ്സ് കാണാൻ പറ്റത്തില്ല, ഈ ഓഡിയോ ലൈക്ക് ഈ ഓക്കെ
ഞങ്ങൾക്ക് കാണാം.
ഓക്കെ, ഓൾ സെറ്റ്.
Okay, തുടങ്ങാം.
Okay, we'll start. Thank you. A very good evening to each one of you.
Okay.
And to the state KGMOA, and special thanks to my
proceed.
sir, Dr. Suresh TN sir.
ഉള്ളതൊന്ന് allow
For always an
കൊടുത്തേക്കാമോ?
inspiring words.
ആ,
Okay,
അല്ല,
we'll
അതൊന്ന്
start.
allow കൊടുക്കാമോ? ടിക്ക് ചെയ്യ്. അതുകൊണ്ട് ആ ഹെഡിങ് ഒരു സ്മോൾ പാർട്ട് ഓഫ് സ്ലൈഡ് ഇസ്
അതെന്താ ചെയ്യേണ്ട? ഓക്കെ.
അലവ് കൊടുത്താൽ മതി.
അലൗ അതിപ്പോ പോയിട്ടുണ്ട്.
നമുക്ക് സ്ലൈഡിൽ കാണാം.
അലൗ കൊടുത്താൽ മതി. ഓക്കെ.
കൊടുത്തോളൂ. ഓക്കെ.
ഓക്കെ.
ഓക്കെ ഡോക്ടറെ.
Okay, we'll start. Okay. So, what I was asked to explain about the red flag signs actually regarding the vertigo. So, when a patient, we all know that we all work in a busy OPD. So, what are the things we should keep in mind when a vertigo patient come, and what are the things we should check for whether to refer the patient or to review the patients? In simple words, I'm asked to explain about the red flag signs in vertigo. But without explaining the vestibular disorders, it's quite impossible. So we'll start the basics. So from the evolution of man, as we see the evolution itself, we can see that initially we used to walk in 4 legs, and later we became bipedal. So as we progressed through the human evolution, there was changes in our spine, our foot, and finally we became bipedal. And this posture itself helped us to maintain an anti-gravity posture, so that to maintain a balanced posture. So how we balance? So for us to balance, we need 3 things. Actually, there should be a sensory input from the periphery. That is through the system of vision, through the vision. And another is through the vestibular system. And then is there through the proprioceptive impulses. So our brain, that is get all the impulses from these 3 structures, especially the vision, vestibular, and the proprioception. Proprioception means the touch. We touch to the ground and we stand. And moreover, all the the proprioceptive impulses from our foot, for muscle tendons, joints, everything, they all send signals to our central processing, that is our cerebellum, brain, and cortex, and they get processed. And finally, this is the outcome. That is, the output is we get a spatial awareness. Spatial awareness means, suppose we are standing in a room. So it tells you which part of the room you are. Okay. And gaze stability. Gaze stability means even if I'm looking like this, straight and turning my head, my gaze is fixed. Like my gaze is stable. So my visual field is stable. So that gaze stability is obtained. And also the postural stability. Postural stability means even if we turn to one side quickly, we may not fall. If your balance is, excuse me, if your balance is intact. So these are the output. So through the vestibular system, it is done through the semicircular canals and another structure called a utricle and saccule, and it contains the otolithic particles. And vision, there is a vestibulo-ocular reflex, which we'll discuss later. And the proprioceptive impulses are from the foot, muscles, and joints. So all these, the central structures like cerebellum, cerebral cortex, brainstem, hippocampus, they have specific cells to identify each movement, and that tells which place you are, and all those things which I told you already. So see, in whatever posture we are standing, we are not falling, because the 3 systems are intact. Suppose we have an OA knee or a fractured knee. So then in such conditions, we may not be able to stand properly. We may fall. So that is because of the improper proprioceptive impulses. And standing in one leg is more challenging. This man is already trained so that he could stand up. Otherwise, if you are untrained, it's difficult to stand because of the incorrect proprioceptive impulses. So standing in a firm ground and standing on a sofa. So this is more challenging. So this we have already discussed. So these are the motor output, vestibulo-ocular reflex, eye movement control, postural adjustment, and finally we get the balance sensation. So regarding the burden of vertigo, just imagine if we have a conference today, we have a presentation today, and we are having in a theater day today, and we have some important work or we have to travel. Just imagine we are getting a bout of vertigo in the morning. So that's it really affect our quality of life, and our work will be compromised. And about 5 to 10% of all patients in GP are said to be vertigo, whereas 10 to 20% reach the neurology and ENT OPD. And especially in elderly, the risk of fall, which cause mortality and morbidities, that is a major risk regarding vertigo. So that is the importance of treating vertigo. Sorry. Moving to the anatomy. See, we know that this is the outer ear, this is the middle ear, and this is the inner ear. So inner ear has two functions. That is the vestibular part, which is comprised by the semicircular canal, anterior. So this is the anterior, and this is the posterior, and this is the lateral. So 3 semicircular canal we have. And plus they open into a structure called utricle. And then utricle is connected to another structure called a saccule. And this saccule, and there is another structure called as endolymphatic sac. So these constitute our vestibular part, whereas the cochlea contribute for our auditory pathway. So we can see that through this opening is called as internal acoustic meatus. Whereas we have external acoustic meatus, we have internal acoustic meatus also. Through this opening, this vestibulocochlear nerve enter from the posterior cranial fossa, and this supply this cochlear nerve supply the cochlea, and the vestibular nerve divide into superior and inferior vestibular nerve, and they supply this vestibular part, that is the semicircular canals. So this is the orientation. If you take a cut section of a skull, see, this is how it is oriented. See, this is how it is oriented from a top view. I already mentioned there is a pathway called as internal auditory meatus. Okay, midbrain, this is midbrain, this is pons and medulla. So from the pontomedullary junction, we have our 7th cranial nerve, 8th cranial nerve, and vestibulocochlear and the facial nerve, which enters into the inner ear through the internal acoustic meatus. So what happens after reaching here? The cochlea will supply the cochlear nerve, and this vestibular is supplying the vestibular part. Whereas the facial nerve is going through here. In our UG classes, this was the most difficult part to learn. That is the medial wall of middle ear and all, and the posterior wall. So the facial nerve passes through this, and it comes to the stylomastoid foramen. And along with this nerve, there is the artery, that is a labyrinthine artery, also enters through this pathway. And how we balance. So this is the physiology. See, I already mentioned, this is the anterior, this is the posterior, and this is the lateral semicircular canal. So it is a semicircular canal, means it has 2 ends. So one end is ambulated, other end is non-ambulated. But here, the anterior and posterior canal, they non-ambulated ends join to form a part called a crus commune, which also opens into the utricle. So we can see that at this thickened area, these are the neuroepithelium. This is 1, 2, and 3. So these are the 3 ambulated end of the 3 semicircular canal, which contain the neuroepithelium. So that neuroepithelium part is called as crista ambullaris. See, what happens is, this is the crista ambullaris. So the vestibular nerve endings are connected to here. So here the man is stationary. So once he moved, what happens? He moved, his head is moving like this, whereas the cupula will move into this. This part is called cupula. So when the cupula is pulled around, what happens? The signals are sent to this vestibular nerve, and this causes action potential, which again reach the vestibular nerve, vestibular nuclei, and to the central pathway. So this is how for the rotatory motions are identified by us. Whereas the utricle and saccule are another 2 structures which also helps in maintaining our balance. So they also contain neuroepithelium, which is called as maculae. So here, unlike here the neuroepithelium is like this. Here also these yellow-like structures are the neuroepithelium or the hair cells. So we can see that this otolithic part, that is the calcium carbonate crystals. So here the patient is head is upright, when he bend his head forward, see this moves. This full gelatin like glue-like structure moves. So then there will be cilia, this hair cells are moved. These sensory nerve cells get signal or the action potential as generated. Regarding the neuroanatomy, in one word, the neuroanatomy is very, very complex. And still researches are going on in it. So we get, I already mentioned from the vestibular part, we got the input, reaches the brainstem cerebellum to the thalamus and which it is connected to various parts, to the vision, to the optic flow, visual landmark, proprioception, audition, motor part, cognitive, psychological, and also to the vomiting centers. So this signifies the psychological aspect and the anxiety, because most of our vestibular disorders, they are aggravated by stress or anxiety, insomnia, etc. So this is the cause, because it is associated with the cognitive and psychological part also. So there is some reflex called vestibulo-ocular reflex, where the vestibular system send a reflex to the eye. So that is ocular reflex, and also to the spine, that is to the muscle spindles, that is called the vestibular spinal reflex. And these are the main functions which already mentioned. After all this central processing, we get the main functions. So we all know that we always have busy OPDs. So when a vertigo patient comes to our OPD, the history taking is the main task, because we have very little time for examination. So, but we have to spend time for taking history, because from the history itself, we should make sure that whether the patient needs a consultation, whether he has to be sent to be cardiologist or a neurologist, or he can be treated in the peripheral system itself. So the patients usually complains of vertigo, which is an illusion of movement of the body. They say that, doctor, ഞാൻ മൊത്തത്തിൽ കറങ്ങി, അല്ലെങ്കിൽ the whole system, എൻ്റെ ചുറ്റുമുള്ളതെല്ലാം കറങ്ങി. That is usually rotatory, which constitute about 45 to 54%, which is usually the vestibular system will be the culprit. Whereas some patients, they say equilibrium. Like what they say is panni nadakkunna pole, or imbalance, like they wobbly. So whenever a patient comes to your OPD, we should have a keen observation how they are coming. They need somebody is helping them, or they are walking alone, whether they need support or so sense of unsteadiness also. These are the things we should ask the patient how they feel. Sometimes the patient has having a pre-syncope, that means sensation of an impending faint or loss of consciousness, which constitute up to 14%. This happens usually in children who stand in assembly end or long standing. So some patients with migraine and all, they say they may have vertigo also, or sometimes they say the lightheadedness. There will be a vague symptom and dizzy or feeling disconnected from the surroundings. That's what they say. So തലകറക്കം എല്ലാ പേഷ്യന്റും പറയും, but we need to know which type of തലകറക്കം, how they feel, എന്താണ് നിങ്ങൾക്ക് തോന്നുന്നത് എന്ന് ചോദിക്കേണ്ടി വരും നമുക്ക്. കൃത്യമായിട്ട് അത് അറിഞ്ഞാൽ മാത്രമേ we can proceed, because this pre-syncopal attack we have to rule out hypotension, any cardiologic pathologies, and disequilibrium we have to rule out neurology symptoms also, neurology conditions also. So these are the non-vestibular causes also we should keep in mind. It could be a simple UTI, viral fever, systemic infection, sepsis, and if it be a pregnancy, hyperemesis, or a gastritis, or orthostatic hypertension, arrhythmias, and could be electrolyte imbalance. And if it's a diabetic, it could be hypoglycemia, peripheral neuropathy, it could be psychological, and any musculoskeletal pathology. All these patients may tell എനിക്ക് തലകറക്കം, or തലകറക്കം, dizziness, giddiness, these are the words. But that's why I specifically told the history is very important. The history list, please explain. They can tell the patient how you feel. So moving on to the vestibular disorders. So we already mentioned there is a particle, that is a otoconia. So we know that the particle displacement causes a disease called BPPV, that is benign paroxysmal positional vertigo. Suppose the whole labyrinth, the inner ear is otherwise called as labyrinth. Suppose the whole labyrinth is inflamed or infected, it causes labyrinthitis. It could be associated with migraine also, which can result in vestibular migraine. And the vestibular nerve may be infected, or it could be a neuroma also. And vascular pathology could be a TIA, stroke, and any another condition called vestibular paroxysmal. I already mentioned there is a fluid inside, that is endolymphatic fluid. The pathology of that can cause Meniere's disease and some bony dehiscence, and it could be due to ototoxicity or any cervicogenic pathologies. These are the conditions or disorders of which we will discuss later. So this is how the semicircular canals are oriented. If you see a top view, it is like this. It is about, see the plane of this anterior canal. This is how it is oriented. It is 45 degrees from the midline. And this is the posterior canal. So it is also 45 degrees from the midline. This explains why we turn the head of the patient 45 degrees in Dix-Hall peg, because to keep this in the more anti-gravity plane. So then only when we do the provocative maneuver like Dix-Hall peg, the particles will move. In such examination, what we are doing is we are provoking the particle to move. So for that provocation to be apt, the head should be in the middle, and it should be in line with the gravity. And the semicircular canal is almost 30 degrees from the horizontal. So this is how it is oriented. This inner part, it is like a tire, which we have in the old vehicles. So there will be inner tire. Inner tire is this blue part. That is the endolymph. It contains the endolymph, which is rich in potassium. And there is an outer covering, that is the perileaf. And in between this, there will be a fibrous connective tissue, fibrous septa, which is connecting these two. So inner is endolymph, which is rich in potassium, and the outer is perileaf, which is rich in sodium. So the outer part is called bony labyrinth, inner part is called as membranous labyrinth. So I just mentioned because to know the orientation. See, these are the semicircular canal, this is the utricle, and this is a saccule, and here you can see the endolymphatic sac. So what happens in benign paroxysmal positional vertigo? Due to some condition, it could be a vestibular pathology, vestibular neuritis, or could be a trauma, it could be a stress, or sudden vigorous neck movement. It could be any pathology, or especially utricular pathology. The otoconia get displaced from that jelly-like structure, and they move into this utricle, and they start moving inside the semicircular canals. So I already mentioned this endolymph, which is usually they do not respond to gravity. But now, since this particle entered, they become more heavier and they respond to gravity. And due to the erroneous signals from our vestibular pathway, the patient develops vertigo. So it could be cupulolithiasis when the particle is attached to the cupula, or it could be canalolithiasis when it moves freely in the canal. The symptoms may differ, and the treatment also may differ in these two types of BPPV. See, here the patient is standing. The most commonly affected is posterior semicircular canals. Here the particle was here. So when they lie down, that is anti-gravity movement. See this, it moved and it entered into the semicircular canal, which resulted in giddiness. So when they, most of the time what happened is the BPPV patient usually comes to our OPD telling that, Doctor, രാവിലെ എനിക്ക് തല കറങ്ങി, അപ്പോൾ ഞാൻ വേറൊരു പൊസിഷൻ അപ്പുറത്ത് തിരിഞ്ഞു കിടന്നു, തലകറക്കം മാറി. So usually they are very paroxysmal because they last for a few seconds. Why? Because if the patient turned to right, അപ്പോൾ patient റൈറ്റിലേക്ക് തിരിഞ്ഞു, he developed giddiness. And patient അറിയാൻ തിരിച്ചു കിടന്നാൽ he will be better. So he may turn to left side and he may become better because the autogonia get replaced. By nature itself, they get replaced. Those patients who come to our OPD with a severe giddiness because of phobia, usually the BPPV lasts for a few seconds. That way it's called as paroxysmal positional vertigo. If they are not improving, if they are not replacing beds, if they are not improving, we have to help them using these menus like Epley's and Simmons. Sorry. See, or this Kadagaramaraka parim, the eyes, Kannagal Kadaparim, same as that. Here also the eyes tell the story. Because there will be, I told you, there is something called as VOR, that is vestibulo-ocular reflex. There is continuous firing of vestibular nerve afferents to the central vestibular neurons to our extraocular motor neurons. That is 3, 4, 6. For example, suppose we have to turn, we are moving like horizontally, like lateral rectus and medial rectus is required, and which is connected to the horizontal semicircular canals. So because of this pathway, that is vestibular ocular pathway, our eyes will get the signals which the semicircular canals are activated. In simple words, see here that he is having a leftward gaze. For left gaze, what all structures we need? We are just move to the left. So to moving to the left, to seeing to the left gaze, we need left lateral rectus and right medial rectus. For that, we need, what are the cranial nerves we need? 3 and 6. And we need 3 and 6. The cranial nerves 3 and 6 are connected to the vestibular nuclei. So this is what I just want to mention here. Vestibular ocular reflex means the ocular motor neurons are connected to the vestibular neurons. So this pathway help in vestibular ocular reflex. So what happens in BPPV? This, when the particles are here, the VOR, that is the vestibular ocular reflex, became altered, and there will be altered sensation. Suppose we moved only 20 degree. But our brain is getting an impulse that we moved some 160 degree. So these are erroneous impulses are reaching our brain, which causing vertigo to the patient. So I told this is the most common. It is sudden onset. Sudden onset because as the patient moved to the provoking patient position, they get giddiness. And recurrent, they are brief attack. It lasts only for 5 to 20 seconds. And there will not be any hearing loss. Usually not hearing loss and no loss of consciousness. Because the patient is അറിയായിരുന്നു എവിടെയാണ് ഞാൻ ഈ റൂമിൽ ഏത് ഭാഗത്തായിരുന്നു and there is no loss of conscience. Most of the patient, they will be anxious because they have phobia that they will fall again. And before moving to the examination, we should always rule out any cervical neck pathology or neck pain. And this is treated by, this is a Dix-Hallpike maneuver, which is the provoking maneuver to check whether there is any nystagmus or giddiness in the provoking position. So here, this in 45 degree, and put the patient down with a head hanging position. So then the particle moves towards the gravity, and this causes giddiness to the patient. And when a patient comes to us, we have to keep in mind these two things. So there is something called as orthostatic hypotension, as we all know. In supine, from standing position, there will be a fall in BP. Systolic BP, a difference of 20, and a diastolic BP, difference of 10. So these are the DDs we should keep in mind. Suppose a dizzy patient is lying down, he is having when he got up, he may become giddy. Suppose he is sitting and standing. This is not he is not moving against gravity. So BPPV is almost always occur following anti-gravity motions. Here he got up and he is lying down. So when he get up from bed and he is lying down, he is becoming dizzy, means it could be BPPV. Whereas sitting and standing or standing for a long time, one comes orthostatic hypotension, or it could be a gait disorder also. And pulse rate and BP is very important in a vertigo patients. In pulse rate for 1 full minute to rule out arrhythmias. And something called as postural orthostatic tachycardia syndrome, because after long time the patient's pulse rate may increases. In such conditions, we have to rule out cardiogenic pathologies. The second is a vestibular migraine. Here what happens is, usually what migraine means, headache, nausea, vomiting, photophobia, phonophobia. Here, instead of headache, we get giddiness. Giddiness, nausea, vomiting, photophobia, and phonophobia. So this is the second most common cause after BPP. As we all know, same as migraine, there will be recurrent episodes. It lasting for 5 minutes to 72 hours. And usually the patient will be having a past history of migraine. Usually when we ask migraine undo, patient will say, illa, migraine onnu illa, enikku angane undailla. But when we ask in school padikkumbo talavedana undairunno, veilu kollappo talavedana undairunno, usually they say yes. And busy povumbo motion sickness. That is also a significant history for eliciting migraines. And migraine, it could be with and without aura, because with or without visual disturbances. Usually, this is a catchy point because they usually become relieved after sleep or rest. We can treat with calcium channel blockers or SSRI. The key point is we should diagnose that it is vestibular migraine itself. So these are the symptoms. It could be vertigo, dizziness. It could be, it may not be sudden rotatory vertigo. It could be sudden rotatory vertigo. It could be a positional vertigo or imbalance or lightheadedness. Migraine patients will get all type of giddiness or spinning sensation like that. There will be associated photophobia, phonophobia, nausea, headache, tinnitus, visual aura, or nystagmus. And these are the triggers, which trigger the migraine will trigger the vestibular migraine also. The pathophysiology means most of the time this migraine pathway, there is a pain pathway, has connections with the vestibular pathway also. I already mentioned the neuroanatomy is very complex. So these are the triggers like chocolate, screen, weather, alcohol, bright light, stress, more screen time, smoking, strong smell, caffeine, and tiredness. And the next condition is labyrinthitis. Labyrinthitis means inflammation of the labyrinth. See, this whole thing is the labyrinth. Suppose here is the middle ear and here is the brain or the meninges. Suppose if there is a meningitis here or if there is a middle ear infection, it could be a tubotympanic disease where there's a perforation here, or it could be an atic perforation here. Here there's a atic perforation which causing middle ear pathology. Here there will be infection or inflammation, and we should keep in mind that this atic perforation or chronic suppurative otitis media aticoantral type are bone eroding diseases. These type are dangerous. That is an unsafe type. They erode the bone. So they erode the bone and they reach here. It could be due to the toxins or it could be to the direct entry of infective infection itself. So this can cause labyrinthitis. So the whole labyrinth is affected. So what will happen if the semicircular canal involved, then they get giddiness, and cochlea is also involved, they get hearing loss. This nausea and vomiting centers are also associated with the vestibular system. Hence, they present with nausea, vomiting also. So any patient coming to us with vertigo, we have to ask for a ear discharge history, and that too foul smelling. We have to rule out cholesteatoma because, as I mentioned, it is a bone eroding disease. It can erode the bone to the brain, and it can. We have already studied in our UG what are the CSOM complications. So all these complications, brain abscess, meningitis, and these things can develop. So this mimic an ICA stroke, that is anterior inferior cerebral artery stroke, which we'll discuss later. In such conditions, we have to go for HRCT temporal bone or CT brain to rule out the other complications also. And the patient has to be admitted and treated with antibiotics and anti-labyrinthine medications. Usually, there will be a history of URA also preceding this episode. So that implies the labyrinthitis. This we have already mentioned. See, this is the internal, this is the temporal bone. The ear is loaded in the temporal bone, and this is the petrous apex. So this is a posterior cranial fossa, and this is a medial cranial fossa. So it is in the margin here, like in the edailan semicircular canal, and this canal lies posterior. Okay, so through this IAC, what all enters I have already mentioned: facial nerve, vestibulocochlear nerve, and the labyrinthine artery. So here is the nerve supply, which we already mentioned. So what happens if this vestibular nerve alone is infected? See, vestibular neuritis is another pathology where there is an inflammation of the vestibular nerve. So here the vestibular nerve alone is infected and not the cochlear nerve. So what happens? Usually they occur after an acute episode of viral URT. This, it is an infection or inflammation. So it will be a sudden onset. Usually these patients present with the emergency department or casualty, they always need support. They will be held by a bystander. And it may last for many days or weeks. As we mentioned, there will be giddiness, nausea, vomiting. The hearing is preserved because the cochlea is not affected. There will be spontaneous nystagmus to the healthy side. Spontaneous nystagmus, we need patient the moment you look to the patient's eyes, there will be nystagmus. That is spontaneous nystagmus beating to the healthy side. And this is head impulse, nystagmus, and test for studation we'll discuss in the next slide. And in this condition, see, this mimics sudden onset, nausea, vomiting, giddiness. In this condition, we have to always ask for any neurological pathology because this is a DD of CBA, that is posterior circulation stroke. Suppose if there are neurological symptoms, we have to do imaging. See, these two nerves, this is the superior and this is the inferior. Here, only the vestibular nerve is affected. Same as we treat optic neuritis, we can treat this vestibular neuritis also with steroids and labyrinthine sedatives, and usually they may need an antibiotic associated with antibiotic also. And moving to the head impulse test. Head impulse test, we already mentioned about the VOR. Here what happens is there will be an abnormal VOR. Sorry. Head impulse test means, see, this patient, this is how we test the head impulse. This is normal VOR. When the patient's head is, we ask the patient to look at the examiner's nose, and the patient's head is turned to right side. And when the patient's head is turned to right side, the eye should move to the left. So when the head is turned to right side, eye is moved to the left. That means it is normal. The vestibulo-ocular reflex is normal. And suppose there is an abnormal vestibulo-ocular reflex and the central connection, that is a central compensatory mechanism, is working. Okay. Then the patient asks the patient to focus on examiner's nose, and the patient is turned to right. Instead of the eyes moving to right, left, the eyes move to the right. And then what happens? Because of the corrective mechanisms, the central corrective mechanisms, they identified that there is something wrong. So due to the corrective mechanisms, there will be corrective saccades again to the left side. So you get this corrective saccade. Whenever you see these corrective saccades, that means there may be some abnormality in the vestibulo-ocular reflex. So that is how we test the head impulse. And also we have to check for any nystagmus, whether there is a horizontal nystagmus, vertical nystagmus, or a torsional. And it is said that the downbeat nystagmus is usually occurring in cerebellar pathology. And whenever we get a downbeat nystagmus, we should be very careful. I have some videos that I'll show later, but something happened with the video sharing, so I couldn't share that. So this is the test for skew deviation. So test for skew deviation means the extraocular muscle signals to the nerves, nuclei in the brainstem is affected. It is definitely a central pathology. So it is called a cover-uncover test. So here we are covering this eye. We alternately cover and uncover this eye. So when we remove this cover from this side, the eye moves vertically up and down. There will be some corrective movements. This is for test for skew deviation. So that is a head impulse, nystagmus, and test for skew deviation. Suppose the head impulse test we got that corrective saccades that usually occurs in vestibular neuritis. In vestibular neuritis patient, we are suspecting vestibular neuritis and we are not getting this head impulse. This head impulse is normal. Then we have to we should be more careful because that indicates the pathology is somewhere else. So next, moving on to suppose we already mentioned about the nerve pathology. Suppose there is a neuroma in this vestibular nerve. So it causes otherwise called as vestibular schwannoma or acoustic neuroma. So what happens? There will be giddiness and there will be associated hearing loss, which is unilateral hearing. Unilateral hearing loss is always an alarming sign. We have to look for other cranial nerve palsy and we have to check for any ataxia, and usually it will be a slowly progressive hearing loss. In such conditions, these symptoms aggravate with as the neuroma increases in size, the symptoms also aggravate. So as it progresses in size, we get other associated cranial pathologies also. So there was a female, a 55-year-old female, hypertensive and diabetic. She used to have recurrent episodes of giddiness, and for 6 months, and she was on Vertin for 6 months. She had sleep deprivation, nausea, vomiting, and all these used to subside after vomiting. She had a history of vestibular migraine also. And the catchy point was history of imbalance while walking occasionally. There was no hearing loss. So when I was talking to the patient, this will make out whether the patient is having hearing loss. But this patient I didn't feel that she was having hearing loss. And when I asked also, she said, no, atra prashna illa doctor. That's what she told. And there was no bystander. And that time the vitals were stable. There was direction changing nystagmus. That means When she was looking to right, she was getting right nystagmus. When she was looking to left, she was getting left beating nystagmus. And she was swaying to right side in rhombus. So we were advised admission and MRI, but she was not willing. And we gave flunarizine. I asked the patient to review. And she came after 2 weeks. That time her symptoms was improved. And then also I advised MRI because she was having this imbalance. And she later presented after 3 months or 3 to 5 months with a bystander. That time the patient bystander told me, that time she was having severe hearing loss, giddiness and imbalance. There will be numbness of the right side of face also. And there was right beating nystagmus. PTA was showing right sensory neural hearing loss and left was normal. And she was having a reduced vibration sense, and the MRI was done. And that was showing a huge phanoma in the right CP angle lesion, which we have referred this patient to the Sri Chitra Institute. This is what happens because we usually miss some things. And after this incident, I make sure that all my vertigo patients will get the PT. 1 minute. Sorry. This was a scan of the patient showing the right CP angle lesion. So this is the vascular supply. So labyrinthine artery is an end artery. Just as we have this coronary artery end artery, we have this labyrinthine artery, they are end arteries. They don't have any other specific supplying branches. So labyrinthine artery is a branch of AICA, that is anterior inferior cerebral artery, which again is a branch of basilar artery. So here the vertebral artery joins to form basilar artery. This is an AICA branch and which supply this labyrinthine artery. So any infarction in AICA, PICA or a basilar artery, it can result in sudden onset giddiness, hearing loss, or associated neurological symptoms with a nausea and vomiting. That's why I mentioned if this AICA, that is anterior inferior cerebral artery alone is blocked, only the labyrinthine artery is blocked. So then the labyrinthine artery is blocked, it will give almost all the features similar to labyrinthitis. So that is the DD. So now the dictum is, if you get a patient with labyrinthitis, we have to do the lipid profile also to rule out any to further stroke and all. So something called as vestibular paroxysmal. So I told, see the AICA is coming like this. So this AICA may loop into these structures. So these are type 1, type 2 and type 3. So this may loop into these neural nerves, that is the vestibulocochlear nerve. So it may cause some short period of vertigo hearing loss. Vertigo hearing loss because both the vestibular and cochlear nerve is compressed. So that is the compression of the vertibulocochlear nerve causing vertigo, hearing loss, tinnitus. It can be provoked by head movements or hyperventilation. And this may occur following any position changes of also. So we have to rule out all other positional vertigo like BPPV, vestibular migraine, etc. So this is the cardiogenic cervicogenic vertigo. There is something called a vestibulospinal reflex. See, this is the cervical vertebra. So the sympathetic structures, sympathetic fibers have connection with the vestibular pathway. This is called as vestibulospinal nucleus. So anything that disrupt this could be a joint pathology, could be a vascular pathology, any joint degeneration. This may cause erroneous vestibulospinal reflex, which result in vertigo to these patients. So this is called as Bow-Hunter sign or vertebral artery occlusion. See here, some patients have only one vertebral artery. The other is stenosed. So this is the only vertebral artery they have. So if they turn to this side, there will be kinking of this. This also result in vertigo and hearing loss. And the whole labyrinth is affected for a short period of time. And when they turn to this normal neutral position, they became okay. They became perfectly okay. See, this is called bow hunter because we have to turn the head to the right side, look up in a bow hunting position. So these symptoms are aggravated in this bow hunting position. So the Meniere's disease, it is unethical to explain Meniere's disease in one slide because it's such a huge topic. And this is a normal year. And see, when the endolymphatic fluid is more, and the endolymphatic fluid is more, or if the drainage is reduced, what happens? The full labyrinth will get enlarged. And this may cause spinning vertigo lasting for 20 minutes to hours, hearing loss, unilateral hearing loss, tinnitus. There will be fluctuating hearing loss, associated nausea, vomiting, and oral fullness. So this episode comes gradually. There will be a low frequency hearing loss, there will be oral fullness, and they aggravate and find later it will come down. And sometimes there will be drop attack also. This drop attack is because of the imbalance in the or the erroneous vestibulospinal reflex. Patient may suddenly fell down because of the musculoskeletal signals are inaccurate. See, this is, if you take a cut section like this, we get this. This here is the endolymph, this white particle. Here is the perilymph. So this endolymph will enlarge and this will enlarge, and finally there will be breakage of this racemose membrane, and there will be mixing of the perilymph and the endolymph. So then this mixing will disrupt the hair cells, both the vestibular hair cells as well as the auditory hair cells, resulting in vertigo and hearing loss. So the treatment of choice is usually we give low salt diet, lifestyle changes, low dose steroids also helpful, diuretics and beta histone also we give to correct the Meniere's disease. And the drug-induced dizziness also we should keep in mind. Sometimes the patient might be taking some benzodiazepines. In such patients, sedation, following sedation also they feel giddy. Adine avaru talakarakam nayirikkum patient parayunnathu, following some medications like NSAIDs, and there's some vestibulotoxic, long-term vestibulotoxic or gentamicin. Here the catchy point is usually after these injections, this vestibulotoxic. So both the vestibular system will be affected. There will be bilateral vestibular padi. So what is this catchy point in bilateral vestibular padis? They cannot tolerate they are unstable in dark. Current if they are going to a dark room, they become giddy. They become unstable. And anti-epileptic drugs like phenytoin could be cerebellar toxic also. And suppose we are taking antihypertensive, patient may develop orthostatic hypotension. That also they may tell they are having giddiness. And peripheral neuropathy also they may be patient may be mistaken as giddiness. And oral so this is why I told the history taking is very important. So BPVC, that is benign paroxysmal vertigo in childhood. So here it's a condition in which the baby clinches to the mother. And usually there will be nausea, vomiting, photophobia, phonophobia. This is usually a variant of migraine. There will be past history of migraine. There will be family history of migraine. Usually the mother will be a migrainer. The history of more screen time, history of motion sickness. Here the most important thing, especially vertigo in children, we have to rule out ICSOL, that is intracranial space occupations or a seizure. Any child coming with vertigo, we have to do a ophthalmology examination, fundus examination. We have to take a pediatric opinion also. After, it's better to have a discussion with the pediatrician, because this is the most DDs, important PDs which we should rule out. And if we rule out all the other central or pathologies, and if we can treat the child with flunarizine, or initially we give with the paracetamol and antiemetic, and if they are not improving, flunarizine 5 milligram dose can be given. And if it is migraine, usually that is the criteria for migraine is included. The patient improves with the flunarizine. That is one of the criteria of vestibular migraine. So, and regular follow-up is required in such children. So, in vertigo in pregnancy, most of the time it may be due to the hyperemesis, dehydration, electrolyte imbalance, calcium deficiency, anemia, hypertension. So, we have to search for the cause, and we have to search for the cause, and we have to correct the cause. And symptomatic management, especially IV fluid, like antiemetics may be needed. These are the conditions which may aggravate in BPPV. BPP may be aggravated, vestibular migraine and Meniere's disease and autoimmune. And if we rule out all these, we have to rule out central pathology also. Pregnancy central pathology and BPPV we can do many years. I got a patient, she was our staff nurse, and in spite of all other medication, she was not improving. And we did many years, Eplis and Simmons I did, and she improved with that. So autoimmune conditions also may flare up in pregnancy. So after all, to conclude, we understood that the duration plays a major role in vestibular disorders. So seconds, it may be last for seconds in BPPV, or it could be an error of epilepsy, or in vestibular paroxysm. It may last for minutes if it is a TIA or in a vestibular migraine. And migraine may last for hours also. And vestibular migraine, Meniere's disease may last for hours. And it may, vestibular neuritis and labyrinthitis. I told it's an inflammatory pathology. So and stroke, it may last for many days. And if it is lasting for many months or weeks, just as I mentioned about that patient, it could be acoustic neuroma or any drug toxicity. Or it could be the cerebellar degeneration, neurodegenerative conditions like multiple sclerosis also we should keep in mind. The history taking, this is a pneumonia, so stunned. So it needs time. At least few minutes we have to spend for this. It's so stunned. Is symptoms. If you can, this is a paper which is available in our online in the site. It's a approach to GDC patient. Symptoms, yes, for symptoms. We ask for symptoms like vertigo, giddiness, hearing loss. Often, how often it's coming? It is acute, whether it has come recently or whether it is recurring. Since when? After a trauma or a viral disease or a neck movement. Today I got a patient, he had a traumatic perforation. Somebody hit him and he had a traumatic perforation. And after that, after the trauma, he is complaining of giddiness, and his Dix Hallpike was positive for posterior semicircular canal, BPPV, and I did a please for that patient. So trauma also can provoke. And it could be a viral disease, neck movements, how it is started. And triggers, what are the triggers? Whether it be a travel, whether neck movements, whether dehydration, insomnia, etc. And otology, ear discharge. And for neurology, evolution, how is it? It is persisting or worsening, and duration. So if we keep in mind this so strong, most of the things are resolved. Most of our worries are resolved in this, I think so. And duration, whether it's lasting for seconds, minutes, whether it's lasting for 20 minutes or more than 2 days. And this is what we always wanted to. A doctor should be a keen listener. And if once we know what are the symptoms, we should ask, we can ask leading questions. And examination starts when the patient is coming to a room itself. The moment we see the patient, that itself gives hint whether need support, how he's walking, he's coming to us, what about his gait, and he's sitting and he's talking to us, whether his voice is deranged, whether he's having dysphonia, dysarthria, and whether he's sweating, his palpitations are there, whether he's anxious. And once we hold his hand, we can feel for the pulse rate, and whether any arrhythmias we can rule out, and pulse rate for 1 full minute to rule out arrhythmias, and BP and orthostatic hypertension, and also to rule out hypertension also. And ear examination, in history itself we got suppose we get a finding that ear discharge, and to rule out chronic separate autism. Fistula test means we press the tragus and check for any nystagmus or giddiness. That is in test if there is any perilim fistula. And eyes, we have to look for pupils also, pupillary reaction, if it is sluggish or in asymmetry, and in nystagmus, whether it's downbeat, I already mentioned. Downbeat is always dangerous. We have to rule out cerebellar pathology, and hints we mentioned. And cranial nerve examination, if we don't get time, at least we can check the touch and pain, because the patient in which I explained, she had touch and pain sensation reduced in the face. So for touch, we can use the whisk of cotton, and we can use this cold instruments like a tongue depressor or tuniform for this examination. And cerebellar test, make the patient always, even if the patient is Seek we know, but try to make the patient stand and withholding them. Give assurance and make sure that somebody is there to help you and make the patient stand and try doing a Romberg and check whether patient is swaying to one side. And Romberg's test means it is checks all the three sensations, that is a vestibular, visual, and proprioception. So when we are asking the patient to with eyes open, if the patient is swaying, that means he is getting vision, vestibular, and proprioception. With all these signals, he is swaying. That means he has some central pathology. With eyes closed, we are checking the proprioception and the vestibular. And if you have to check the vestibular alone, we can ask the patient to stand on a foam bed, then or a foam bed, but then the proprioception also is denied. So then only the vestibular alone we will be checking only the vestibular. And Underberger test is I'll show that video, and the vibration sense to rule out any peripheral neuropathy. And if possible, we can check the knee jerk and ankle jerk also to rule out any neuropathies and other neurological severe pathologies. These are the red flag signs: any neurological deficit, ipsilateral hearing loss, if he needs support, and a direction changing nystagmus or a downward nystagmus. Always check for sweating, palpitation, chest pain, discomfort, any abnormal vitals. If the symptoms are persisting, worsening, associated nausea, vomiting, we have to think of any central stroke and meningitis, and we have to check for neck stiffness. Also, a history of loss of consciousness, whether previous history of CAD or CVA, associated comorbidities, and psychological aspects also. And these are the investigations I already told. See, there are specific nystagmus for specific canals, so which we get through the video nystagmography. These are the goggles attached, and we do these menus with this, and we get the typical, we can see the type of nystagmus, and thereby we reach which canal is affected, and thereby we give the appropriate menus for them. So these are the other tests we do, WEM, chair rotation test. These are the tests we can do, which we don't have at present. And pharmacotherapy, we can treat the patients for a anti-labyrinthine sedatives, that is a sinarsen diamond hydrate or chlorpromazine, beta-histine. So in the initial stages, we can give. The most important thing is we should know which pathology. Suppose the patient is having, we realize the patient is having BPPV and he is very much anxious, or if he is having severe nausea, vomiting, because horizontal semicircular canal. So in such conditions, we have to make the patient calm. In such conditions, we can give sinarsen or some labyrinth sedatives, and then do the test once the patient is stable. But without knowing the pathology, it is unsafe to keep on loading the patient with all these medications. Prochlorperazine is an effective vestibular suppressant. It can give in casualties in emergency situations. Suppose a patient is having a vestibular migraine or any vestibular neuritis in such conditions. It will take care of the anxiety part also. And the beta-histine, how it acts. See, it acts in the histamine receptors. We can see that there are a lot of receptors. Receptors are there in different parts. It is there in the endolymphatic. This is the central part, midbrain pons and medulla. So here is in the central vestibular neurons also they have. Here also they have actions. In the endolymphatic sac also they have. In Scarpa's ganglion, that is the ganglion for the vestibular nerve. There also histamine receptors are there. And the vestibular hair cells also they have receptors. So all these areas, they beta-histine act. And the mechanism of action is central nervous system. They rebalancing, that is rehabilitation they have, and brain arousal. Whereas in vascular pathology, vascular tree, that is in the blood vessels, they help in increasing the cochlear blood flow. And in peripheral labyrinth, they help in decreasing this is the decrease in vestibular input, because see, one labyrinth is hypo, the other become hyper. So we have to keep that in balance. So this is how it acts. So we have to use this medicine very judiciously and only after attaining our diagnosis. And always rule out stroke or tumors or infections in patients with vertigo. So management is always a teamwork. Reassure the patients, repositioning menus for BPPV, and pharmacotherapy if needed. And rehabilitation means suppose the patient is having muscle dystrophy and they may have some neck pathology, they may have fibromyalgia, and they may have this peripheral neuropathy. In the conditions, we can give exercises and all. And there are specific vestibular rehabilitation exercise also. And never hesitate to do cross consultations, ask help from our physicians, neurologists, pediatrician, and our ophthalmology friends, and psychologists also, psychiatrists also, and the psychological aspects also should be considered, and refer to higher center if needed. And always you should have a discussion with the with whom you are referring, and for a better outcome. And these are the challenges. We have already less quality time, and as the token number increases, both the doctor as well as the patient become exhausted, and patient and bystander education, the lack of vestibular testing and rehabilitation, these are the challenges we face. And suppose we sometimes once the crowd increases, we'll be like this, but we should learn to smile, and we have to, because after all we have a life, we have to maintain our work-life balance. So these are my references, and a word of gratitude to my teachers. As you all know, I did my UG in Kottayam Medical College, as Dr. Shibu sir has inspired many others. He has inspired me also. And my guide, Dr. Goyal, has always inspired me to learn Vertigo. And Dr. Srinivas Derisala had taught, whatever I've taught now is taught by him. And the take-home message is, all that spin is not BPPV, and all that posterior vertigo is not BPPV. Whenever the patient say that, when I turn my neck, I got giddiness, I develop giddiness, it could be BPPV, it could be vestibular migraine, it could be vestibular paroxysmia, it could be a Bauer-Hunter syndrome. And also we have to search the cause before suppressing the labyrinth, because if we keep on giving, we know that there is something called a central vestibular system, which always try to rehabilitate. Compensation is coming from the central vestibular system. So if one side is compromised, the other has to be compensated. It has to be compensated using the vestibular rehabilitation by the central mechanism. So we should not suppress our labyrinth. So always search for the cause, and we all know the art of balancing need immense hard work, focusing on the aim. Thank you. Thank you, KGMOA, for giving me a wonderful opportunity to discuss this.